Welcome. I would like to explain the topic of fat embolism to you in this video sequence. A fat embolism occurs when fat droplets enter the bloodstream and block vessels, which mainly occurs after bone fractures or operations, especially on long bones such as the femur or pelvis. Fat embolism generally occurs within 12 to 72 hours after the trauma or surgery. The exact likelihood of suffering a fat embolism varies and depends on the circumstances of the trauma. It occurs in about 1 to 10% of patients with fractures or operations on the long bones. The symptoms of fat embolism often develop within 24 to 72 hours after surgery. They include shortness of breath due to the blockage of pulmonary vessels, confusion and impaired consciousness. Fat embolism can affect the brain and cause neurological symptoms. Small, pinpoint bleeding on the skin, especially on the upper body, neck, and armpits. Racing heartbeat and increased body temperature are also common signs. Complete prevention is often not possible, but the following measures can reduce the risk. Short operations, gentle surgical techniques, i.e. minimally invasive surgical procedures, can reduce the likelihood of fat embolism. Fluid therapy, adequate fluid intake after trauma or surgery can stabilize blood circulation. Treatment is primarily aimed at alleviating symptoms and ensuring oxygen supply. Common measures include oxygen administration to increase oxygen saturation in the blood, fluid management to counteract circulatory disorders. I would now like to explain to you the possible ways in which a fat embolism can develop. To do this, you need to understand a few anatomical facts. We're talking about the following anatomical structure for long tubular bones. They have a compact stabilizing outer shell, inside of which lies the bone marrow. In the shaft area, this is the yellow bone marrow substance, and in the metaphysis area, it is spongy, i.e. sponge-like material. In adults, the fat content in the bone marrow space is significantly higher than in children's bones. This is why it is also called yellow bone marrow. This yellow bone marrow is also very well supplied with blood vessels. In this picture, you can see the thigh again in cross-section. The arrow marks the height of the cross-section. I have also marked the outermost layer of the thigh, that is, the skin and the subcutaneous fat. Please note the light representation in comparison to the dark central bone. Here you can see individual muscular septa on the cross-section plane. The femur is now in the middle of the thigh. On the outside there is the hard bone substance in the form of a tube, and on the inside there is the yellow bone marrow. In this cross-section, you can clearly see the difference between the light subcutaneous fat tissue and the gray muscle, as well as the black hard bone substance. The marrow space within the bone has almost the same light structure as the fatty tissue in the skin. This fatty medullary cavity is now prepared for the nail during the operation and drilled out accordingly so that the nail fits exactly into the medullary cavity. When the nail is inserted, the pressure in the lower area of the long bone inevitably increases, like an air pump. This leads to an increased risk of fat particles being forced into the bloodstream and causing a fat embolism. For this reason, we always carry out a compensating drill above the knee during leg lengthening. This means that the pressure in the lower end of the long bone cannot increase as much because the pressure is diverted outwards via the cannula. This significantly minimizes the risk of a fat embolism. The cannula is removed after the nail has been inserted, leaving only a small cut in the skin.